These are the same things going on. Final result. PDA. Very simple thing. Many babies have it. Don't need surgery for closure until and unless they are very, very big, out of sizes for the. You have a simple, what you call, in a bottle you put a cork, we put a cork in the connection and it is closed. This is the communication between aorta and pulmonary artery. You just take this catheter there. You have wired across from aorta to pulmonary artery. You have got in with the catheter. This is the device, this tip you see, black. This is the device which has been deployed already. 2 discs. It closes the hole. There is no PDA left after that. Why this poor child will be opened up when you can close it without opening up? Strokes, ischemic strokes, one of the commonest morbidities. Can you tell me why the most common ischemic strokes happen? Where do the thrombotic element come from that go and clog the middle cerebral arteries? It's the neck. The commonest site is the neck. In the carotid arteries, where you have plaques. You see this carotid artery on the right. Can you see the cut? I don't know whether I'm not using the arm. Can you see the cut in the carotid artery? Once again it will go on. Look here. There is a distinct wedge. Here it is. Yeah. This is the right. Can you see the? I'm going on doing it. Can you see the wedging? A white line angularly among the dark thing. Could you appreciate? See this one. That is the wedge of plaque that is inside. So if that remains over there, you will go on having dehiscence from there and into the middle cerebral artery. What you do is simple. You take a distal protection device and you open it up and you see the artery is very smooth. This gentleman will have no recurrence of stroke from this lesion any further. So in an ischemic stroke, if you leave the substrates out there, they are going to have perpetual strokes. But you open it up and then give your antiplatelet therapy, there will be no perpetual strokes happening, recurrent strokes happening. This is the final picture with the stent. Carotid artery looks beautiful. Again, a patient comes to you with refractory heart failure, getting repeatedly admitted in your CCU with LVF and uncontrolled blood pressure. Do not forget the renal arteries, because they are a cause of resistant hypertension leading to flash pulmonary edemas. See the renal artery opening up, the renal artery stenting. The indications have become limited now. But a person who has repeated episodes of LVF like this person, you see the renal artery, it has become so much narrowed. This is the original size and it has become very thin out here, almost as thin as the wire. What did we do? We opened up with a balloon. This is the stent going in. Put in the stent. What did you achieve? This person never came. She's actually the mother of one of the chief of police in Asansol. She never came back here the next time for a heart failure. She was on 7 antihypertensive medications. Till date, that has got reduced to 2 after opening of the renal artery. So this is the benefit that you can achieve. A procedure that takes you 15 minutes, giving you this much of relief from morbidity and mortality. This is what I was talking about. You see the bleeding in the lung. This is the right bronchial artery, upper lobe. You see the bleeding in the lung. Dr. Shantanu Das, midnight, came to us with this gentleman who has roamed about the country with this hemoptysis with no avail. Last time he was admitted in CMC Vellore before getting admitted to mission. And 12 o'clock at night, Dr. Das comes and tells us that there is a hemoptysis that has to be stopped. Can you see the torrential bleeding in the lung bed? From this article, can you appreciate it? That there is a torrential bleeding in the cavity. And this is after we have stopped it with the coils. These are the coils, and there is no arterial supply to the periphery. This gentleman walked home after 7 days and still today gets followed up in his OPD without any further hemoptysis or lung complications. So can you imagine that this is a thing which is available to you, but just we don't have time to appreciate. I have been talking about unspoken interventions, but I would love to end with a topic close to my heart. See, there are very few places in the country who has access to primary angioplasty in acute myocardial infarction. You are one of them. Remember one thing, if you take the cost dynamics into consideration, a person who has been admitted within 3 hours or 4 hours of a heart attack, if you can open up with a TNK-TPA at your institute, instead of going in for a streptokinase. Streptokinase is very, very, very cheap, I know, 1500 only. So if you can give streptokinase, cannot give anything other streptokinase, give it as early possible. If not, a little delayed, start TNK-TPA. Because TNK-TPA is one of the drugs which open up the arteries in more than 75% of the cases, vis-a-vis streptokinase which opens it up in 45 to 52% of the cases. Try to look for whether you have got a successful thrombolysis. How do you look for successful thrombolysis? Very simple 4 things. Chest pain decreases, the ECG area, the area under the ECG curve decreases. These are the 2 principal points. If you see, you will understand that you have done a successful thrombolysis. If it is not, the thrombolysis is unsuccessful. My dear friends, today, keeping a patient who has been successfully thrombolized or who has not been successfully thrombolized, lying in the CCU for days together is adding to morbidity and cost. The next stage, what you should do is, you should have a check shot of the arteries to see whether the successful thrombolysis has led to a complete resolution. In that situation, you just ask the patient to walk home with 2 or 3 preventive drugs. If it has not opened up, open up the artery and send him back to work after 3 to 5 days on drugs. But the more the patient stays in the CCU with unopened arteries, more and more muscle mass is destroyed. More and more LV function goes down, more and more morbidity increases, and you get nothing out of that patient any further. This is nothing, this is a patient who had come to us with a low ejection fraction, 20% was the ejection fraction, having recurrent syncope because of VT. He had a widely dilated QRS complex with LVBB, and this is a combo device that we put in. This is a CRT with an ICD combination. This is the device. These two are the coils across which it gives shocks, and you have three leads, one in the coronary sinus, other in the RV, the third in the RA. So this is the ultimate device by which you can give a productive life to a person with such a low ejection fraction. This gentleman could afford it. Affordability is a question, no doubt here, but he's roaming the world with this on. When he came to us, he was a class 4 patient on drugs. Thank you very much. I will not love to talk anything theoretical, because I think what sees says more than what we speak. So it is seeing that matters. If you have any interest in coming to our lab, you are all welcome. We can show you procedures which you may appreciate that such things can be done. But these are so simple things that if you quote Rabindranath, then you can find that we ignore small things to look for bigger things. But it is the small things by which we can achieve much more than by looking at bigger and bigger things. You open up CTO and try to show that I'm opening up a chronic total occlusion. You open up very tortuous arteries and you try to show that we are opening up very tortuous arteries. Well, our cardiologist scholar go up when we show those. But it is for all where you can take advantage of a cardiovascular division to make your patients safe. Thank you very much.